Okay. Assalamu alaikum wa rahmatullahi wa barakatuh. Uh, Welcome, everybody. I can see the number is increasing. So we'll give them just a few seconds. All right. So, Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome, everybody. And welcome again for one of our cardiovascular evenings. And tonight, the discussion is about shingles and cardiovascular disease. We've been um, يعني sharing the governmental recommendation for shingle vaccination for people above 50 and above 40, and adding risk factors from here and there. And then now there is an extension of the recommendation, especially for quite a vulnerable segment of our community, which is patients with cardiovascular diseases. And for that, inshallah, tonight we will be accompanying Dr. Walid Al-Habib, who is the a professor of cardiology and medical director of Al-Habib Hospital, as well as he's the president of the Saudi Heart Association. And I'm a proud dear friend of mine. And the discussion will be about shingles and cardiovascular disease. Without further hesitate, Prof. Walid, the floor is yours.
Thank you, Prof. Kamal. It's a real pleasure being with you tonight. And it's a delight actually talking about such a topic. I do thank GSK for um, uh, sponsoring such an event and making it possible to get us all together and talk about something out of the norm. Um, as cardiologists, we are used to talk about uh, acute MIs, about heart failure, being a heart failure cardiologist, and other cardiac diseases. When we talk about infection, probably the most we talk about is myocarditis or pericarditis, with uh, hesitation because of our ignorance and lack of knowledge. Now, we definitely have been talking about infections and their role in worsening heart disease and worsening cardiovascular disease. But shingles specifically is as important, if not one of the most important infections, worsening cardiovascular disease. Um, so, um, just uh, a few declaration of interest. Now, let me talk a little bit about the story of shingles. More than 90% of adults above 50 years of age are infected with varicella zoster virus and are at risk of shingles. We all recall when we were kids, and many of us had chickenpox. Maybe it's less common right now because of the vaccinations that are given to the child to children in their young age, but it's still, if not, um, if it doesn't show with flourish chickenpox in the young, it still causes infection that becomes dormant. And up to 1 in 3 people will develop shingles in their lifetime due to varicella zoster virus reactivation. The incidence is huge worldwide, um, and are similar between countries. Overall rate is about 6 to 8 per 1,000 persons at the age of 60. And in the US, for example, 1 million new cases of shingles each year, 1.7 million in Europe and 1.5 million in China. In our population, the elderly population, which is more than 50, constitutes 44% of shingles patients in our country, and that goes with the overall statistics. Why is that so? It's simply because of our immunity with age declines. In the young, in childhood, we get the primary infection, as I said, and that induces zoster specific cellular immunity. This cellular immunity may be boosted periodically via exposures or silent reactivation, but our immunity during teenage and young adulthood is still strong to combat that. Now, when the immunity declines with age, that decline in cellular immunity is associated with an increased risk of the reactivation of the virus, which we call shingles. And as many studies have shown, the incidence compared to those less than 19 or in their 20s is much lower than those in the age above 50. Even post-herpetic neuralgia is much more with older age. So if you get it in your 50s, you're less likely to have post-herpetic neuralgia compared to those who are in their 70s or 80s. And many cardiovascular conditions by themselves affect our immunity. So it has been thought that our immune system dysregulates, and many inflammatory pathways get activated with our cardiovascular conditions, whether it's just simple atherosclerosis, a myocardial infarction, pericardial disease, heart failure, hypertension, or even rhythm disorders. And any acute cardiovascular event will also affect our immunity, increasing the risk of reactivation of the virus. So about 34% increase in relative risk of developing shingles in patients with cardiovascular disease. Higher risk of shingles was reported in the group compared to patients without cardiovascular disease in many studies. And shingles itself is associated with increased risk of cardiovascular disease. So you have a 78% relative risk increase in stroke after 1 month of herpes zoster, a 25% increase in MI incidence, a 22% risk of arrhythmias within 2 years, and a 14% risk of coronary artery disease within 2 years of herpes zoster infection. So many studies have indicated this correlation. So it's like a vicious cycle. Your cardiovascular diseases depress immunity or dysregulate immunity, reactivating the virus. The infection with shingles itself increases the risk of cardiovascular diseases. And this has been shown in many studies, just pointing out a few studies that have shown a risk of increased MI, for example, by 60%, ischemic stroke 50%, heart failure by close to 50% as well in one study. In several other studies have showed that whether it's a overall cardiovascular disease, heart failure, hypertension, worsening coronary artery disease, stroke has been significantly increased by varicella zoster infection. Now, most studies indicate that the risk of cardiovascular events is highest in the first weeks and months of infection with herpes zoster and decreases over time. In one study, the relative risk of stroke or TIA following herpes zoster in the first month as you can see, was significantly high, up to 78% increase. At 3 months, 43%, 1 year, 20%, and more than 3 years, it was the risk was negligible. As such as and goes as well with the risk of myocardial infarction events following herpes zoster at one in the first week up to 68% and drops lower until the 13th or 14th week, which drops the risk of development. So the crucial part and the most risk is in the first few weeks and months post infection. Now, a little bit about shingles itself, landscape and cardiovascular disease. As we said, more than 90% of adults above the age of 50 are infected with varicella zoster and are at risk of shingles. So you get the infection in your childhood with your immunity. This goes into latency in the dorsal root of the ganglion root, and with reduction of immunity by any means or for any cause, you get virus reactivation and you get zoster or shingles. And it just remains again latent in dorsal root ganglion, and you can get several reactivations actually. The acute presentation, as we all know, is just a vesicular rash, mostly unilateral, and the pain is excruciating, often described as aching, burning, stabbing, or shock-like. Several complications can occur after the infection, most commonly post-herpetic neuralgia, one of the worst pains described. And this is neuropathic pain that persists for months and affects about 30% of patients with shingles. It can also cause herpes zoster ophthalmicus, affecting about 25% of the patients, and may lead, in some cases, to vision loss. Other symptoms of headache, photophobia, malaise, and fever, but other complications or common complications could be a disseminated disease, scarring, neurological complications, Ramsay-Hunt syndrome, which includes hearing loss, Bell's palsy, cardiovascular and cerebrovascular events. Recurrence: 6 to 10% of patients experience a recurrent episode. So that it's not just that they get the first episode; it can still happen and recur again with all this. It's complications. And as we have highlighted, that it's very much related to the immunity. So these symptoms may be more severe and complications more frequent in immunocompromised patients. The pain has been on a scale of comparing to other pains have been have been described to be worse than labor pain. So it's one of the most severe pains that a patient can have. And unfortunately, with this infections and reactivation and pain, quality of life of these patients is significantly affected. That can affect the emotional function, of course, cognitive factors, social, physical functioning, activities and daily living, hobbies, sleep, even eventually work and career can be affected by this complication. So now we're having a disease that already happens in childhood. We've been able to depress it or reduce it by some of childhood infections, but again, it's by some childhood vaccinations. It still occurs. It lays dormant. It reactivates. How can we prevent this from happening? And that's the good role of our vaccinations, and specifically Shingrix. We all have lived during this era with many recurrent infections, and as a major example, COVID, which has hit hard, and we were able to prevent it and prevent its complications by vaccine as well. Influenza vaccine that we keep on recommending to be given every year, and other vaccinations. Now, this disease, which carries real complications and affection of quality of life, I think it's very worth um, talking about the vaccine. So I'm not, as I said, an infectious disease or an immunologist. I'm a cardiologist. So the main focus here is to talk about the disease and the recommendations. Um, I'm not the best one to talk about the vaccine itself, but apparently there is a new adjuvant system that incorporates the most common antigen, the glycoprotein A, which is the most abundant at the surface of varicella zoster virus and is expressed during the episode, and it targets the humoral and cellular response. So it's a recombinant subunit non-life vaccine, and it has been studied very well on efficacy and safety, which I will be touching on in the coming few slides. Um, the Shingles vaccine was studied in two large pivotal phase 3 clinical trials, the Zoe trials, the Zoe 50 and 70, 50 years and above and 70 years and above. And it was a randomized, observer blind placebo controlled trial, which included more than 16,000 patients in the first one and 14,000 in the second study. And it looked at the efficacy against herpes zoster, post-herpetic neuralgia, and other complications. And it was in 18 countries. Unfortunately, our region was not part of it, hoping in future that we get more involved in trials. Now, what the highlight was that Shingrix delivered 97% efficacy against shingles in patients above 50 years of age, and in about 91% in those above 70. So it showed significant efficacy against the disease. The final analysis showed that this protection lasts up to 11 years, with 87.7% overall efficacy at 11 years. And that's a significant efficacy for such a vaccine. And even at 11 years, no safety concerns were identified. Um, the vaccine efficacy against herpes zoster in patients with medical conditions, specifically hypertension, dyslipidemia, and coronary artery disease, was significantly high as well, with 97% of coronary artery disease patients. Um, the numbers of side effects, deaths, and potential immune-mediated disease were similar in vaccines and placebo groups. And most reactions were mild to moderate with a median duration of 2 to 3 days. And this is well expected in all vaccines, actually, that you get some local reactions, pain, redness, or swelling. You might get some myalgia and fatigue or headache, fever, general reactions. But as you can see, they were very low compared to placebo. No increase in serious adverse events were mentioned or were found, whether serious adverse events, deaths, or potential immune-mediated diseases, comparing the Shingles vaccine to the placebo in all age groups. Now, it's a two-dose vaccine. So the second dose is given a month later, and that gives a 4-time higher protection. That is very important that we realize that and remind our patients that with your first dose, you will get some protection, but not it's not complete until you get the second dose, um, which gives you quadruple efficacy. And co-administration with other vaccines like influenza, pneumococcal, pneumococcal conjugate vaccine, tetanus, diphtheria, acellular pertussis, DPT, or TDAP, is possible, but at different sites. It's nice to show the evidence. It's nice to show the effect, but how did that translate into our practice and our guidelines? Many recommendations have been clear about it. Our MOH, Ministry of Health recommendations, that Shingles uh, is 2 doses, 2 to 6 months apart for adults age 50 or older, is indicated for prevention of herpes zoster and post-herpetic neuralgia in adults 50 years of age or older and adults 18 years of age or older in increased risk of herpes zoster infection. And very similar, the USA guidelines, but the highlight is that I thank all the contributors to the paper. The Saudi Heart Association has recently written a paper on vaccinations in general in cardiovascular disease, and soon will be published, has been accepted for publication, will be released very soon. And we highlighted specifically because it's for cardiovascular disease patients. Here, just to show vaccination of recombinant zoster vaccine, RZV, with a 2-dose series of the recombinant zoster vaccine, Shingles, should be considered for patients with cardiovascular disease aged 50 years or older. Now, I encourage you all to look forward to this paper, as it will touch on all vaccinations. Our precious cardiac patients needs protection from all vaccines. As you know, we've been recommending for our patients annual influenza vaccine, now COVID vaccine as well, periodic pneumococcal vaccine. Meningococcal vaccine is crucial for our population because of Hajj and Umrah and pilgrims. But it's very important to consider these vaccinations for our patients for protection against worsening um, heart disease. One important note to press on, and that's what I really encourage all of us. I know we're all busy in our clinics and our practice, and as I said in the beginning, we're not uh, accustomed to talking about infections and vaccinations. But as I said, our patients deserve that from us, and it has been shown that once the doctors or the clinician, the primary physician himself recommends it for the patients, the possibility of complying jumps by 3 times. Our patients trust us. They believe us when we tell them that they need it. There are several means of delivering the message. We've been hearing a lot about um, vaccinations in the media, and people read about it here and there. But once they hear it from their own doctors, they trust it more, and they more likely to receive it. So I do recommend and advise all our colleagues and myself, including, to remind our patients of taking such vaccines. Um, and with this, I would like to end and thank everyone for joining. And we're open for questions. Thank you very much.
Thank you very much, Dr. Walid. It's quite a devastating disease, especially when you look at it that's hitting people above 50, and especially that they have other comorbid disease. And the pain is enormous. Sometimes when it hits the face and it hits one of these cranial nerves, it's unbelievable. So when you mention something about the side effects, I know that we always worry about what happens if I get vaccinated, I'll be sick. I think it's worth it, the malaise and the because whatever comes with the vaccine, it's nothing like, God forbid, the real thing. Do you agree with me, Dr. Walid, on that?
I definitely do. I mean, as you said, first of all, these side effects are mild. Second, they're not a must, so not everyone will have it. I mean, the maximum, if you get any malaise, is probably 20-25% of the people. There's a chance that you won't get anything. It could be just some local reaction of a pain or redness that we get with our influenza vaccine or any other vaccine. So I think the side effects should not push us against at all taking such a preventive and protective measure. The risk, if not taking it, is the significant complications that happen, and neuralgia is only one of them. As you've seen, it increases the risk of stroke, MI, heart failure, hospitalization, and it's devastating in our cardiovascular patients.
And you did mention something about the MOH recommendation for the 2 day two doses for people above. Now we're saying people, not patients. Am I right?
So the two doses is for everyone. If you have the second dose increases your protection by four times. So the recommendation is two doses. Who is it recommended for? It's recommended for 50 years and older, and for those who have cardiovascular disease, and 18 years and older if you have any comorbidity that depresses your immunity. But for the general population, it's not recommended.
Very good. And honestly, I'm impressed about the efficacy. I mean, 90 to 97% for 11 years. This is pretty much more than most of our practice and medication that we give.
That is true, and even if it comes, it would be lighter. And one thing to highlight that even if you had an infection, you should still take the vaccine to prevent a reactivation. As I've shown, that 10% of people, up to 10% might have a reactivation. So it should be taken even if you get a previous infection.
Yes, and you know that now we have the very strong recommendation for influenza vaccines. And as you mentioned, Hajj is inshallah coming soon after Ramadan. So we will go also into other vaccines related to Hajj, like meningococcal and all these things. So the co-administration is quite safe because that's a common question I get, that can we get them both or one is enough?
No, you should get all your vaccinations. Now you can co-administer it with influenza or pneumococcal. Meningococcal, I'm not sure. Maybe it needs to be at a different time.
Yeah.
Now, it's very interesting that, and this is something that we have touched on during our paper writing, which I think is unique, that um, all Saudi Arabia should be considered endemic for meningococcal, pneumococcal, because we are all exposed to pilgrims. Umrah now is all year long. Now, people who have been going to Mecca, and I recently, alhamdulillah, went to Mecca recently, it's always crowded. People coming from out of the kingdom, it's not a season anymore. It's not only Hajj season. Our Hajj season is all year long, and people travel between Mecca and other cities of Riyadh, of the kingdom, including Riyadh and Jeddah. And so I think all people uh, residing in Saudi Arabia should receive their vaccinations as if they are going to Hajj, because we are exposed all year long.
Well, you're 100% right. I mean, the amount of air trafficking above the kingdom for the local flights are enormous. Thousands and thousands. You're absolutely right. So, if you have a final Prof. Walid, sorry, final recommendation about cardiovascular disease as a strong recommendation for vaccination, what would be your final recommendation?
So, as you know, um, cardiovascular disease is the number one cause of mortality in Saudi Arabia, and some reports up to 40% of the causes of death. And the morbidity behind cardiovascular diseases, including hospitalizations, absence from work, quality of life affection, is tremendous and huge. And it's very obvious that infections increase the risk of worsening cardiovascular disease, mortality and morbidity. Shingles specifically has been related very much to the increased risk of cardiovascular diseases, whether it's stroke, MI, heart failure. And if we have such a means, a simple, easy means of preventing such a thing from happening, I think it's our responsibility as clinicians, as people taking care of our patients, to make sure they take it. It should be one of our checklists. In whenever when you follow your patient, I understand you're looking at his blood pressure, at his heart rate, at his medications, at his diet, at his physical activity. Don't forget his vaccinations. At least أقول لهم أقل الإيمان, which sometimes when I'm very busy I make sure that he has a visit to the family physician downstairs to complete his vaccinations. That's what I'm saying. Many times I forget, and I do understand. You don't remember how many times should he take the pneumococcal? When is the last time he took it? How frequently should he take the RSV vaccine, his influenza, his varicella zoster? It's a long list. Yes. The least they can do, which I really make sure they do, is that I ask them to go down, visit the vaccination clinic, the family physician clinic. The Sahati program already has a list of the vaccines that he has taken and not yet taken. He visits, he gets the recommendation, he gets the doses taken. Alhamdulillah, it has been working very well for my patients, and I think it's our responsibility all over the country.
Yeah, 100%. I think we've covered most of the points, and I don't see any questions. So I believe with that, I would like to thank you, Prof. Walid, for this precious recommendations. And as usual, we always learn from you. And thank you, Taj, for the organization. And, and thank you, my dear audience, for attendance. Um, yes, there are no questions. So thank you, everybody. We'll hope we meet again. Inshallah, jazakumullah khair. Assalamu alaikum.
Yeah, it was a pleasure. Wa alaikum salam. Thank you very much.